Heart patients who have faulty heart valves causing the heart to work inefficiently are finding options and opportunities for treatment that weren't available just a few years ago. Dr. Richard Bianco, a retired oral surgeon from Champaign, had a heart murmur for 15 years, but it was only last September that he became very ill.
And all of a sudden it seemed to get bad quickly, and that kind of brought it to my attention. And then it got bad very quickly where I couldn't walk more than 20 feet or so, and I could feel my chest tightening and struggling for breath and shortness of breath. And had a couple of incidents several weeks before I came to Springfield.
Dr. Bianco's aortic valve was faulty. His illness brought him to the outpatient clinic at Prairie Heart Institute for a consultation, but as it turned out, he'd be staying a while.
Dr. Mischel knew that you were a very sick man.
Yeah. Well,
he decided it was best for you to stay here
yeah,
and have this done,
yeah.
and then I assume you agreed with him too.
I did agree with him.
Mm-hmm.
I didn't realize how sick I was, until a couple of weeks before I got down here, and I was thinking pretty fast. I do know enough about it. I'm not a cardiologist, but I know enough about that I was running out of time.
Dr. Bianco learned that he was a candidate for a non-invasive procedure known as TAVR.
Dr. Mischel, the word TAVR is familiar to our patients, even though a lot of them may not know what it means, but it's an acronym.
Right.
And it's TAVR for, and correct me if I'm wrong, transcatheter aortic valve replacement.
Right.
Okay, TAVR. And what it means is patients used to have their chest cracked to have an aortic valve replaced.
Right.
But it's not that way anymore,
Right.
all the time anyway.
So, the terminology has evolved along with the technology. So we also now call surgery SAVR, surgical aortic valve replacement, and we have transcatheter aortic valve replacement. What's the difference? Well, in surgical aortic valve replacement, the bottom line is you have to put the patient on the heart-lung machine, so that's a big difference between TAVR and SAVR.
Mm-hmm.
And the second big difference is a surgeon cuts out the old valve and sews in the new valve.
Mm-hmm.
With TAVR, transcatheter aortic valve replacement, about 90% of the time we put the valve, and it's essentially the same valve as a surgical valve. We put the valve on a catheter, a stick if you will, and we come up through the groin, the femoral arteries, and we go into the aortic valve, and we then deploy this new TAVR valve inside of the old valve while the heart is still beating. So the major differences are essentially no incision. Number two, still heart beating, not need for a heart-lung machine in the vast majority of patients. And the old valve stays behind. Where does it stay? Well, it just basically gets pushed to the side by the stent that the valve is sewn to. So these valves are created just like surgical valves. I mean, people think I'm getting a pig valve, I'm getting a cow valve. That is true. But the way these are actually, all of these valves, surgical or TAVR, are actually constructed from the biological material either in the pig or a cow. They're not actually the valve. It's the biological material that surrounds the heart, called the pericardium. And a worker, and these are very well-trained workers, actually sew leaflets together onto a frame. In the case of surgery, what we call a sewing ring, and then the surgeon takes out the old valve and sews the new valve in. In the case of a TAVR, it's sewn onto the inside of a stent. So the stent expands, pushes the old valve to the side, and you're left with the new valve operating normally.
And I told my cardiologist I kind of like to look into the TAVR procedure, see if that would work for me. And immediately he said, then I'm going to send you to Springfield.
And this is from Champaign?
This is from Champaign.
Okay.
Christian Clinic, Champaign, which is where I practiced for 4 years. And I came down there and, I was impressed. by everybody I met.
So the old valve just kind of gets crunched to the side, and then it's kind of used as maybe part of what anchors the new valve.
Yes, that's very intuitive.
Wow.
Because the old valve is old and calcified, and in fact, to some extent, it's this calcium in the old stuck valve that holds the new valve in place. Now you'd think, my goodness, how can that possibly be? But through several mechanisms, either through very high pressure balloon expansion or self-expansion of the stent, it's just held in place. No sutures, no nothing.
So I see two big advantages here. One, you don't have to cut through the sternum to get to the heart. And number two, isn't it a big advantage not to have to go on the machine, on the heart-lung machine?
Well, to be honest and transparent, right now we know that it's a big advantage in people who are inoperable, meaning they can't have surgery, and obviously this is an alternative for somebody who can't have surgery. And TAVR is a big advantage for somebody who's very high risk for surgery, because even if they do well with the surgery, the trauma of what you're talking about, the incision, the heart-lung machine, just the assault on the body, these patients can spend a fair bit of time in the hospital. So I think it's fair to say, yes, TAVR is a big advantage. We know that for a fact for patients who are inoperable and high risk. The next question is it a big advantage for somebody who's lower risk for surgery? Because again, I want to stress, we never want to sacrifice a good long-term result for maybe some short-term gain or perception of gain. So one of the important things that we're doing with TAVR, and we're going to know the answers to this probably within a year, is if we take patients who are at intermediate risk, half and half, what's the advantage for TAVR in those circumstances? And in fact, we've completed a study, a randomized study. We were one of the 50-odd sites across the United States that looked at this, where we randomized patients who were considered intermediate risk to surgery or TAVR. And we're going to find out the results to your question, which is there an advantage? Now, if it turns out that they're both equal, then most patients would say, assuming that the valve is durable, I'd probably like to have the less invasive thing done. And that's what I think consumers will demand at some point in time. Then if that's shown to be true, then the next step is, what about patients who are low risk for surgery, who are younger? We need to be able to do this as well as the surgeons, who can do it with a very, and actually I shouldn't say the surgeons, because surgeons work with us on this. This is a shared responsibility. This is not a he said, she said. This is not a competition. This is surgeons work with cardiologists side by side in these procedures, and we make a joint decision about it. So the question is, if you're low risk for surgery, the surgery can be accomplished with a 99% success rate. Is there, can we compete? Can the TAVR technology compete with that 99% success rate, since it's so low risk? And can we be sure that if you're young, this valve is going to be as durable as the surgical valve? And so we're slowly working our way through to answer that question. We know, again, in summary, high risk inoperable, yeah, I do think big advantage for the patient not to be cut on, not to be on the heart-lung machine. Middling risk patients, we're going to know in the next year. My suspicion is that it's going to be roughly equivalent to surgery, and I think consumers will want to have a less invasive option.
91-year-old Elaine Hillman of Carbondale was also faced with the need for a new aortic valve.
Elaine, you just celebrated a birthday?
Yes, December the 4th.
Which birthday was that?
91.
91. And at the age of 91, you made a big decision about your health, didn't you?
Oh, yes.
What did you decide to have done?
Replace the valve.
Your
the
aortic
heart.
valve, huh? Now, I understand that you've been thinking about this for a while.
The doctors have been thinking about this for a while.
Okay, yeah.
Not me.
It wasn't on your radar screen.
No,
huh? They thought you
wasn't.
might feel better if you had it done, but you weren't so sure, huh?
No, I wasn't.
Well, what made up your mind for you? What made you feel like it was time?
I began to feel a little worse, and I couldn't do the things that I always had done. So I decided, well, I don't want to sit around and be an old woman, so I'm going to get something done. And if it works, that'll be fine. If it doesn't, why, doesn't make any difference anyway.
But you weren't feeling all that great 2 or 3 years ago. You must have reached a point that convinced you. Was it just tiredness, or were you in pain, or
No, I wasn't in
symptom?
pain.
No.
I've never been in pain, but I just got to where I couldn't do anything that I wanted to do,
Yeah.
and I'm the kind of person that want to do something all the time, and I couldn't do it. So I decided that maybe if I had this done, that I could have a few more good years.
Yeah, yeah.
Yeah.
You know, it's remarkable when you think about the doctor taking a new aortic valve and putting it into your heart without having to cut you open. That's pretty amazing.
Yes, I wouldn't have gone the other way. No, I wouldn't have done it.
Yeah, yeah.
But this way, I see this doctor went up through the groin area and put a stent in, and so that wasn't bad at all. So I'm hoping that this is not going to be bad either.
So you thought if he can do that, then he can put a valve in there too.
That sure he can.
Yeah, yeah.
I'm sure he can.
Well, all the best luck to you, boy. We sure hope that in a few days you're just feeling a whole lot better, a whole lot more energetic. Is that kind of what you think?
Yes, I want to feel better. I want to be able to do things and go things. And I just passed my driver's license, so I want to be able to go places.
Right. Well, all right. Now, all you have to do is build yourself a car, and there you go, right?
Well, I have a car.
Oh, you have a car, okay.
I have a car, yeah.
Okay.
So, yeah.
Good luck.
I'm not finished yet.
No, you're not. You're not.
Elaine, as it turned out, was also a candidate for the TAVR procedure. We visited with her again just one day after the procedure.
Elaine, it was just yesterday that you had your new valve.
Yeah,
put in.
practically a new heart.
Practically a new heart?
Yeah.
Really? Well, a new valve anyway.
Yes, it is.
Yeah? How are you feeling?
I'm feeling fine.
Have you been...
I'm feeling fine. I'm just a little bit shaky because I haven't eaten anything for 2 or 3 days.
Yeah.
But that's all.
I'll bet, do you have an appetite yet?
No, I don't want anything yet.
Yeah.
But I will.
Yeah.
Because I have a good appetite. I eat everything they give me.
Have you been up and around?
With their help, I just walked around there.
Really?
That's
great.
all.
One day after and you'll probably be in a. Are you going to a normal hospital room here?
They're
pretty
going
quick?
to put me in a room right away.
Yeah.
Yeah,
Yeah.
that should be a normal.
Yeah.
I don't know what kind of room it is, but I hope it's a nice one.
Well, it'll be instead of ICU, it'll be in a regular hospital
Yeah.
room. Yeah, and you'll be able to watch TV and have guests and just be there for a little bit. You won't be there
Yeah.
very long, probably.
I don't think so. I'm not planning on it. I'm planning on going home.
When are you planning on going home?
Oh, in about 3 days.
Is that right?
Yeah, I hope.
Yeah. And then when you get home, I mean, do you have any plans?
The only plans I have, of course, I won't stay by myself for a while because
Right.
I'd be afraid to. But I have a friend, Fran Swartz,
Uh-huh.
that's going to come and, if I need her, she said she'd come and stay with me.
Yeah. Well, good.
So I'm going to take her up on it.
Yeah. You just look like you feel good. You can tell when somebody feels good. You look like you feel good.
I do feel good.
Yeah.
I do feel good.
Yeah. Congratulations.
Yeah, and I'm just so relieved because I was really concerned. I thought, after all, I'm 91 years
Right.
old, and any
Yeah.
kind of surgery can be a little bit dangerous.
Yeah. Yeah.
So, but I made it fine.
You sure did.
He's a wonderful doctor.
Dr. Nandish, you have an appreciative patient.
Well, I'm glad.
She looks like she's doing okay.
She's doing great.
Yeah. Did you encounter any difficulties with her TAVR procedure at all?
No, she did great. I think she was very motivated to get this done. She's an excellent patient. She, was sure exactly what she's going to do after the procedure. That helps us. She wanted to get it done, wanted to go home in 2 days. That's what she wanted to do. And the procedure went just perfectly well.
Yeah.
So everything went well, and she's doing great.
For a 91-year-old woman, oftentimes you don't know what to expect, do you?
Right.
Because, older people have downturns.
Right.
But in this case, there was nothing unexpected, huh?
No, well, the thing is, what helps us is the rigorous process we go through in planning the procedure. It takes about 2 to 4 weeks to really plan the procedure well. And we look at every aspect of it, how we can get to the heart, what kind of valve we're going to put, in what size valve we're going to put. We also anticipate issues which could happen during the procedure, after the procedure. So putting all things together makes a big difference when you have a planned procedure and you go in, you do the procedure, and then everything turns out well. It makes a big difference in that way.
Now she has a mechanical valve in there now, right?
Well, it's more of a, what we call as a bioprosthetic valve. It does have a strut which is made of metal, but within that, the valve itself, the tissue, it's made of a tissue.
Oh, okay.
Yeah.
All right. So will that this is designed to last her the rest of her life, I assume, right?
Yes, definitely.
Yeah.
They should at least last for 10 to 15 years from what we know from before. These particular valves, the newer type of valves, the data is not out there for 20 years, but for 5 to 7 years for sure.
And as far as her recovery goes, when do you think she can go home?
Well, the way she's done, she wants to go home today. Well, we like to, right? There you go. But I think, most typically we can send her home the second day. That means like tomorrow.
Right.
If she's up to it, now today she's already walked around. She feels great. If she's feeling great tomorrow, she can go home tomorrow.
Yeah. Well, that's great. Thank you for visiting with us.
No problem. All right.
Meanwhile, Dr. Bianco is resting comfortably, quite satisfied with his decision to go ahead with the TAVR procedure.
I don't remember anything about the procedure. I mean, I know they sedated me to get me started, and after that was a piece of cake. I woke up in the recovery room and felt perfectly fine. Very little pain, little anesthesia fog, which I expected. And I was very pleased with how slick it went. To the point I said, well, that wasn't so bad. And then I thought about it a while and I said, well, that's a pretty major procedure.
Dr. Bianco's wife, Audrey, was also relieved, especially when recalling the last 18 months.
But he's been having a breathing problem for probably a year, 18 months. Kind of started out as wheezing, and then, then he got to gasping, and then, like in the early fall, he was really, really bad. One night we went to the movies, and I had to call 911 because I thought I was going to lose him in the car.
And you were pretty sure that this was the valve issue, that the valve was the...
Well, we had been told that his heart was real strong, so something was, the heart was working, but it was very, very inefficient. So,
Describe the day when you all came over here and he was admitted.
Well, it was a real surprise to be admitted. We thought we were just coming for a consultation, and then we were going to go home and wait until we got the surgery call. So that was a little bit of a shock. But we were okay with it and happy that we could get the, all the whole process started without any delay. And I talked to Dr. Mischkel after the surgery. Shelley had taken me back, and he kind of swung by and he stopped, and I told him I was so grateful that they didn't delay, because we really didn't think he was going to last much longer without having, some sort of maybe a cardiac event.
Now, your husband did a lot of research
Yes,
going
he did.
into this, and he decided that he wanted to come here for this. How did you feel about that?
Well, I was right with that. I wanted him to go the best place possible. He's really always said that if anything serious happened, we were not staying in Champaign. Not that there aren't good doctors at Christie or Carl. We just were going to go to the absolute best place we could find. I think we're going to have a lot more years together. We've only been married 22 years, so, we're going to have a lot more years, and we can vacation, because he started out great when he retired 5 years ago, but probably within a year and a half he started one thing after another. So I hope that we can do a lot more travel. I don't know whether he'll be able to play golf again. I know he'd like to, and I would like him to, but I don't know that his other problems will prevent that. But at least he won't be gasping for breath, and he'll be able to walk.
Not all heart valve replacement patients are candidates for the TAVR procedure. Some choose SAVR, the surgical approach. 51-year-old Thomas Miller of Springfield was suffering from heart failure about a month before he opted for a minimally invasive replacement of his aortic valve.
Right, so the traditional approach to a surgical aortic valve replacement would be what we call a midline sternotomy, where you literally saw the chest in two, retract it to the side, put the patient on the heart-lung machine, and do your operation, expose the aorta, open it up, expose the aortic valve, cut it out, put it in. The beauty of a sternotomy is, first of all, although it's a big scar, patients are frankly surprised by how painless that is. It's really, and so it's not as painful an incision as you think. But the beauty of a midline sternotomy is that the surgeon has unbelievable exposure. He can see everything. And I believe, my surgical friends tell me that one of the tenets of surgery is exposure. You can't sew what you can't see. I believe that's the term we use. But over time and with technology and experience, surgeons can actually go in with what we call little keyhole incisions and can visualize the valve and have learned how to take that valve out through this little keyhole and put a new valve in. And I think that's the trick, to try and get as good a results as you can when you've got excellent exposure, but obviously leaving the patient with a smaller incision. And for many patients, that's very important. It's not just the pain, there's what we call cosmesis, the cosmetic effect, and also return to work. It does take time for bone to knit, probably in the neighborhood of 4 to 6 weeks, to get good bony union. So for many of those patients, they basically sitting around until that bone can heal, versus a small incision that would literally heal maybe within a week or two. And so I think that there are advantages in terms of cosmetics, there are advantages in terms of pain, potentially, there are advantages in terms of return to work, time in the hospital, potentially.
Well, Mr. Miller, do you feel like a new man yet?
Not yet. I'm confident I will, though.
Yeah. An
Still feeling aortic valve replacement.
Yeah. You know, the day was when they would have had to cut your chest wide open to
I
get
got
that
to miss
in there.
out on that.
Yeah, you got to miss out
Yeah.
on it, yeah. And you wouldn't be feeling probably quite as good as you are right now if you'd had that
No,
procedure.
that's not what I hear. I hear you'd be a long time.
Yeah, yeah. How
Laid
do
up
you
in a lot
feel?
of pain. Surprisingly good now. Like I say, anxiety's been most of my problem. I can't explain it. I just think I worry about every little thing. You know.
Well, don't you think everybody who's had a surgery like you did is going to feel some anxiety?
Yeah, but I think some people are probably better at handling the anxiety. Or my wife claims she would be anyway.
Let me ask you about the way you were feeling leading up to this, and what convinced you that you needed to have surgery.
I was tired all the time. I was sweating a lot at night, just sleeping. Fingers were getting numb and tingly. I'd get some occasional pain down my arm and neck, and I'd feel like a lot of palpitations, I guess you'd call them, from the heart working too hard, trying to push blood through, since one of the flaps on my valve had basically ceased working. So only 2 of them are closing out of the 3. So I think all that just I couldn't work out anymore. I was working out and started feeling less and less like being able to do anything on the treadmill, just not feeling well afterwards like I thought I would. You know, I used to always feel good after I'd, get a workout in. And that was probably about 1.5 years ago that I just couldn't do any of that anymore. And I went to the doctor and got a complete physical. And actually the doctor I went to told me everything was all right. I went to St. Anthony's and got a different doctor because I wanted a second opinion because I thought something was wrong. And he actually found it like in the first 2 minutes he saw me. So.
Oh, he knew right off the bat that it was your valve, your aortic valve. Huh?
He knew that I had a serious heart murmur.
Uh-huh.
And he was guessing it was the valve. He couldn't tell just by listening.
Yeah.
But that was only October 12th. So he got it rolling quickly.
Yes, he
after
did. So you had about 1.5 years where you felt lousy in there.
Yeah.
Yeah.
And was it getting worse and worse as it went on? It
Yeah,
was?
Yeah. Yep. I wasn't feeling good. Like I say, the sleep was a big thing. Just couldn't sleep. I was tired. And the other symptoms I told you about. Sorry, I've been medicated a lot. I kind of forget what I've said sometimes. But
Yeah. But you were a candidate for this particular procedure.
Yes.
And for the valve, they put a tissue valve in, so
Yeah,
you're a candidate
yeah.
for that.
Yeah.
And you probably feeling pretty good about this going forward, aren't you?
Yeah. I think the valves are lasting longer and longer now. I've passed up on the mechanical just because I didn't want to take Coumadin, and that's what you have to take for your blood thinner now. I drive 80 miles one way to work.
Oh, is that right?
Yeah, I mean, I could, if I had a minor car accident or something on Coumadin, I mean, I could bleed out, before anybody can do anything about it.
Yeah.
And I work with a scalpel all day too, sitting in my, microscope. So that could, something that used to just be a little annoyance could become an issue.
Sure.
If I cut a finger.
Yeah.
So I thought the tissue was the better option for me.
Options are clearly changing and increasing in number for those with bad heart valves, sometimes offering permanent solutions and shorter recovery times.